It's important filtration of the lateral sulci of the prostate. The prostate-specific antigen, as we said earlier, is a blood test that done to detect the levels of the PSA in the bloodstream. PSA is a serine protease released by the prostatic epithelium as well as seminal vesicles, and it breaks down the seminal in seminal fluid. And this helps to reduce the viscosity of the semen and promotes the motility. Generally, the levels of the bloodstream tend to be quite low, and these increase when you have a condition that is disrupting the architecture of the prostate. So, any inflammatory condition or any manipulation of the prostate may lead to the PSA going up. The PSA was approved first in 1994 by the US FDA for the early detection of prostate cancer after a pivotal study that demonstrated that the 4.0 nanogram cutoff was effective. However, it must be said that even with a PSA lower than this, it's still possible. And so one must not be overly enthused about the fact that the PSA is lower than 4. At least 2 separate PSA tests are required to confirm the increase. So a single PSA test does not warrant further movement towards a biopsy. You must repeat this test before you progress to any further evaluation. What are some of the possible causes of the PSA elevation? So prostate cancer is one. You can also have an inflammation or infection of the prostate gland, benign prostatic hyperplasia, which is non-cancerous enlargement of the prostate gland. Recent ejaculation has also been found to cause that. So it tends to rise within an hour of ejaculation, may last anywhere up to a day or two, up to 48 hours. And so for patients that are PSA, you should ask them to abstain for at least 48 hours before doing the test. Urologic instrumentation as well may lead to elevated PSA. What's the role of screening in prostate cancer? So screening is basically defined as a systematic examination of an asymptomatic population to identify individuals who are at risk for a specific disease, and this is usually done by the health authorities. The main objectives of screening are to reduce the mortality of the condition as well as help to maintain the quality of life of the patients. So for prostate cancer screening, there are 2 major modalities that are utilized, the digital rectal examination as well as the PSA. And best evidence supports the use of the serum PSA for early detection of prostate cancer. The DRA should not be used as a standalone test because in the early cases, you may not palpate a tumor, but there may be presence of a cancer. And so this is used as an adjunct to the PSA in prostate cancer screening. What are some of the major publications that we've had regarding prostate cancer screening? One of the major ones was in the US, where they evaluated about over 76,000 patients. That was rectal and ovarian cancer trial. They concluded at the end of the study that there was no significant difference between the control group in terms of mortality from those who had been screened for prostate cancer. There was another study in Europe where they evaluated over 180,000 patients, with patients having PSAs as well as digital rectal examinations being done. They found there was a 20% reduction in prostate mortality, prostate cancer mortality. However, you needed to screen about 1,400 plus patients and treated about 56 or so, no, 46 before you see one patient from prostate cancer. As they continue to gather data over the period, I think perhaps about 16 years or so since they started this study, they found that the number of patients you actually have to screen had dropped from about 1,400 to about 570. And you need to treat much less patients as well to save one person from prostate cancer. So that's also quite encouraging. So there tends to be a bit of controversy regarding whether prostate cancer screening should be done or not. What are the pros of prostate cancer screening? We are hoping to identify patients early enough with clinically significant cancer where we can intervene with a bit to reducing the mortality and morbidity associated with the condition. We want to decrease the proportion of patients that are coming with metastasis at the time of diagnosis. And also to reduce the mortality rate. So false positive, when as we said, there are other causes of so those could account for becoming indolent. That will not cause any symptoms and will not cause mortality. However, these patients will be picked up with prostate cancer screening and subjected to treatment that will not otherwise have benefited them. And so there's a risk of overdiagnosis and overtreatment when you do prostate cancer screening, as well as the various complications of doing a biopsy of the prostate. Bleeding, and the most feared one is sepsis that can be life-threatening. All these complications may occur and may not be warranted in the individual case of the patient. So as we said, prostate cancer screening remains controversial. There are contrasting recommendations from various guidelines, and so when before is done, care should be taken to evaluate the patient in totality. I mentioned we have a patient with a stroke, 70-something, unable to walk, face deviated, and is coming because of an elevated PSA. This is not the sort of patient you want with the evaluation. So you must evaluate them fully because this patient may not survive the biopsy data. Sepsis may rather be the cause of the patient's demise. So they must fully understand the risk and benefits that they stand to gain from prostate cancer screening. According to the EA guidelines, who should be screened? So patients who are older than 50 years of age, because of the high risk for prostate cancer in the African population, once you are 45 years and above, when you're African, it's recommended that you have screening done. If you've been found to have a germline mutation on testing, then screening should start at 40 years of age. And those who are older than 45 years as well, who have a family history of prostate cancer, should be screened. So generally, also they recommend that we should stop screening in men who have a life expectancy of less than 10 years, based on their comorbidities, as well as by the age of 75. Men who fall outside of these guidelines, but who come and see you requesting a screening, should be fully counseled about this, and if they are insistent, the PSA test should be done. Patients who would not benefit from the testing or who refuse the treatment probably should not be screened, as may not be able to go forward with any further evaluation. So it's important to know that prostate cancer represents a spectrum of disease. You can have an indolent cancer that's not going to be life-threatening, may be completely asymptomatic, and you may have a more aggressive form that's a significant cause of mortality. Differentiating between these two can be a challenge, and because of this, we're having increasing costs, even increasing cases of overdiagnosis and overtreatment, because it's difficult presently to distinguish between the two. So there are modalities that have been brought to try and help identify whether you're dealing with an indolent disease or a disease that's likely to be more aggressive. And so the EAU guidelines of 2023, as we stated, will recommend that if you have an elevated PSA test, before you proceed to any further invasive evaluation, to repeat the PSA first, prior to doing any further investigations. For patients who have a PSA between 3 to 10, and the DRM is normal, they recommend that you use one of the following tools to assess the need for a biopsy. So there are risk calculators available that help to determine how fit the patient is for a biopsy and what the risk for prostate cancer is. They also recommend that you do a magnetic resonance imaging of the prostate gland, which will help to guide the decision as to whether to do a biopsy or not. They also further additional testing that haven't entered mainstream. These include serum and urine biomarkers that can be done in a bid to further improve the decision as to whether to do a biopsy or not. So apart from the PSA, there are various, so the PSA density, which is the PSA level over the volume of the prostate. If you find that the PSA, the value is between more than 0.15, this tends to be more predictive of prostate cancer, and this may push you to go ahead with a prostate biopsy. This is especially for patients who have a PSA between 3 to 10. The free PSA also as well is another test. So the PSA circulates in the bloodstream. Part of it is bound to proteins, and the other part of it is free. Generally, when you have prostate cancer, the level of the free PSA tends to drop. So those whose free PSA is more than 25% are unlikely to have prostate cancer, and this may help you as to whether to make the decision for the biopsy or not. As we said, the multiparametric MRI will allow for men to avoid the biopsy. It allows for visualization of areas that are likely to have a clinically significant cancer prior to the biopsy, and allows for reduction in the diagnosis of insignificant cancer, and helps in the improved selection of patients for active surveillance. So when you do a multiparametric MRI, on the T2 weighted imaging, you'll be looking for any hypo-intense areas. With the diffusion restricted imaging, they're looking to see whether there's movement of water molecules within the prostate. So the areas that have prostate cancer tend to have more restriction of movement of the molecules. And then whether these areas will enhance with contrast. And this gives you an idea of what the likelihood for prostate cancer is. So following that, usually you find that they will give you a PIRAT score, prostate imaging reporting a data system score, with the PIRAT 1 being highly unlikely to be prostate cancer, increasing all the way to a PIRAT 5, where the risk for prostate cancer is quite high. With the advent of the multiparametric MRI, however, it's important to note that it should not be used as the initial screening tool. So you don't request a multiparametric MRI when you have not done a PSA, whether you have not done a TRE, when you have not repeated a PSA. So it's not recommended to be used as an initial screening tool. So generally, they also recommend that you have the MRI done before a prostate biopsy. This can help guide which type of biopsy you may do. Lesions that may be located anteriorly may be more difficult to access transrectally, and so a transperineal biopsy may be indicated in that case. Patients who had previous biopsies as well may benefit from a multiparametric MRI from output biopsy, as this may also help to guide the biopsy. So as we stated, there are some biomarkers. One of them is the prostate health index. So this is a combination of the total PSA, the free PSA, the pro-PSA test. And patients who have a value less than 25 are less likely to have cancer. This is also utilized for patients with a PSA between 3 to 10, helping to guide the decision as to whether to do a biopsy or not. Another serum biomarker is the 4K score, and in this one, they are combining the free PSA, the total PSA, the human kallikrein, and also consider the age, the DRE, and other features to make a decision as to whether this patient will require a biopsy or not. We also have some of the urine biomarkers, select MDX, urine PCA3, and some of these are genes that are found in the urine for the urine PCA3. So if you find this in the urine, then the risk of you having prostate cancer is higher, and so you may warrant a biopsy of the prostate. Genetic testing is also important. Increasingly, treatment for prostate cancer is being individualized. So if you have germline mutations, then your treatment can be modified to account for this with use of some other agents. So how is the prostate biopsy done? So you can do it transrectally. Previously, it used to be done mainly digitally. So finger guide, you have the finger in the rectum and guide the needle to take biopsy from the prostate. Now, mainstream usually we tend to do it as an ultrasound guided procedure. You may also do it transperineally, and then you may do an MRI targeted biopsy. And this may be either through the transperineal or the transrectal approach. So you have a tumor on the MRI, multiparametric MRI of the prostate that's located posteriorly, where you can access digitally. Then a transrectal ultrasound guided biopsy using the MRI information may be warranted. If the tumor is more located anteriorly, then a transperineal biopsy may be more value. So for this one, you can do a cognitive fusion where you mentally picture where the lesion is, and this helps you to guide placement of your biopsy. And then you have softwares also that combine the MRI information with ultrasound, and this can help to guide the biopsy of the prostate. Or you can have this done in the MRI suite, and where this helps target the lesion in the prostate. So the image to the left shows the transrectal, sorry, the pointer isn't working. Shows the transrectal ultrasound guided biopsy of the prostate being done. You have the probe being inserted into the rectum, and the needles are then inserted posteriorly. So the probe is in the rectum, being exposed to the fecal matter in the rectum, and then your needle goes through this into the prostate gland. So obviously the risk for infections are much higher with a transrectal ultrasound guided biopsy of the prostate. A transperineal biopsy on the other side goes through the perineum into the prostate, and so the risk for infections are much lower. And so outside, a lot more of this is being done. I think they are moving a lot away. But if you can access the lesion posteriorly when you do a rectal examination, then a transrectal ultrasound and guided biopsy of the prostate may still be helpful. So biopsy, a report will come. Usually they will confirm the presence of a cancer. The commonest one we tend to find is an adenocarcinoma, a tumor of the glandular tissue of the prostate gland. We can also have other histologic subtypes. So they'll state how many cores of the tissue. So sorry, typically during the biopsy, 12 cores of tissue are taken from the prostate gland. So 2 at the base on either side, 2 in the middle, and then 2 at the apex on either side, coming to a total of 12 cores. And so they'll state how many cores of tissue are involved in the tumor, what the percentage of that is, whether there's perineural invasion as well. And all of this helps to guide the prognosis for the management of the condition. You also have the grading of the cancer. So the Peter Gleason score, where the first figure you see represents the grade of the predominance pattern seen in the tissue, with the second score being that of the most undifferentiated grade seen. Recently, there's also been a shift to using at least the International Society of Urological Pathology grade group system, where we group, when you tell somebody they have a Gleason score of 6, it can be still quite frightening because you wonder that you move all the way from a 1 to a 6. So when they look at the pattern under microscopes, the score of 1 and 2 tend to look a bit more normal, so those are rarely used. So most of the scores start from a 3. So because you're having 2 numbers on a scale of 1 to 5 on either side, the least you get is that of a 6. So when you tell somebody that their score is that of a 6, sometimes they can get frightened. And so when you look at the new scoring system, the grade group 1, you have a score which should have been 6, but this is now a group 1. And so that's a bit more relieving for the patients as well. It's also important to note that a Gleason, for example, the Gleason group, the grade group 2 and the grade group 3, while they both have scores of 7, in terms of prognosis, is quite different. So those who have the first score of 4 tend to have more aggressive cancers, and the prognosis is worse. And so this helps you also to prognosticate and inform the patients about what the likely outcomes are going to be. Staging is important, so it helps you to determine the extent of the cancer spread. So for example, if you're doing a physical examination for a patient with a known prostate cancer and you find tumor, you find an extruding eyeball or hard masses on the scalp, it gives you an idea that you may already have metastasis to these various areas. But clinical investigation is also important. Applying phosphatase elevation may help you to know that you may have bone involvement. And then imaging is a mainstay of the staging. What options do we have available? So we can do an X-ray. However, this you need quite a significant amount of tissue of bone involvement for the X-ray to show. So you tend to have osteoblastic lesions being seen on the X-ray. So these are dense white areas of bone for deposition within the bone, and these usually is pathognomonic of prostate cancer. A bone scan is done using technetium-99 with an MDP, methylene diphosphate, and may show up. So we describe these dark areas as hot spots. It's also important to note that areas of increased bone remodeling, for example, somebody who has osteoarthritis, so you may have some of these in those areas. And so these must be borne in mind when you are looking at the bone scan. So you look for areas that are not weight bearing and may not be involved in these, so that somewhere around the ribs, if you find these hotspots, it's more likely to signify metastasis to those areas. So following this, we'll tend to group prostate cancer into localized disease, where the disease confines the prostate gland, locally advanced, as well as metastatic disease. So with metastatic disease, you have spread to various organs, to the bone, to the lungs, and various other organs within the body. So what treatment options do we have? For patients who have localized prostate cancer, if their life expectancy, so if they have low risk prostate cancer, that's to say that the PSA is less than 10. DRE, when you do a rectal examination, the tumor may be not palpable or just localized to less than half of one lobe. And then their ACID score is 6. So these patients, their life expectancy is less than 10. They will benefit from watchful waiting. So with that, we're taking a decision that we're not going to treat with any curative intent. We'll monitor these patients and observe them. So if they have any complaints of back pain or there's evidence that there's disease progression, then we treat with palliative intent to make sure they remain comfortable. So this is a bit not to impair the quality of their life from the treatment modalities that they otherwise would have been subjected to. You can also do active surveillance, where the decision is taken in patients who have low-risk prostate cancer to treat with curative intent. But in a bid to maintain their quality of life, we delay the treatment and monitor the PSA digital rectal examination with repeated biopsies until there's a change in the parameters which indicates that there's disease progression. And then treatment is effected in a bid to cure the patient of the prostate cancer. You can also do a radical prostatectomy or external beam radiotherapy as well as brachytherapy. There are some other focal therapies that are available that the recommendations from a lot of the guidelines are that these are many clinical trials. So you have the high intensity focused ultrasound, you can have the cryotherapy, etc. But these are not in mainstream use. So with the active surveillance, as we mentioned, you'll be doing regular digital rectal examination findings yearly, PSA testing every 3 to 6 months. Glasings for biopsy of the prostate may be repeated every 3 years or so. And then you keep monitoring the patients until you see a change in the parameters, and then that will push you to then go ahead with the biopsy of the prostate. As we stated, watchful waiting, life expectancy less than 10 years, asymptomatic, low risk cancer, and you monitor them as the change in their clinical condition, and then you treat palliatively. Radical prostatectomy entails complete removal of the prostate gland together with the seminal vesicles and then original lymphadenectomy being done. So once that's done, the bladder is reanastomosed to the urethra. Obviously, one of the major possible complications is that of urinary incontinence. And so before doing this procedure, one must fully counsel the patient about this. And intraoperatively, every effort must be taken to maintain the full length of the urethral length in a bid to avoid damage to the external sphincter and maintain continence. Erectile dysfunction is also another possible complication. External beam radiotherapy, I'll leave that in detail to my senior colleague. Prostate brachytherapy as well. So this is low dose brachytherapy entails insertion of radioactive seeds into the prostate gland. I'm sure she'll talk about that in a bit more detail. So these modalities are all available in the country and are being done. So these are pictures showing the prostate brachytherapy being done at the Kodagu Teaching Hospital. The patient is on the bed, anesthetized, probe is in the anus, and then together with the radiation oncologist, the seeds are radioactive seeds, commonly iodine. You can also use palladium or cesium. These are inserted in the prostate gland to deal with the prostate cancer, or localized prostate cancer. And these are images showing the brachytherapy seeds in situ. For patients who have locally advanced prostate cancer, where the cancer is beginning to extend to surrounding structures, a combination of either radical prostatectomy together with long-term hormonal therapy of at least 2 years, or external beam radiotherapy with long-term hormonal therapy is of benefit. The hormonal therapy refers to use of things that will modify the effect of testosterone on the prostate cancer. Testosterone stimulates the normal prostate tissue to grow. Not a similar effect of prostate cancer. So if you're able to suppress or take away this effect of the testosterone, it helps suppress the division of the prostate cancer cells. And then finally, with patients who have metastatic disease, in that case, there's no option for a cure, and the treatment is mainly palliative. So as we stated, this is on the basis of the the hypothalamic pituitary gonadal axis, where we suppress production of luteinizing hormone either from the, so we can give what we call luteinizing hormone releasing agonists. These will act at the level of the hypothalamus and stimulate initially release of luteinizing hormones from the pituitary gland, which will then stimulate release of testosterone from the leading cells of the testis. With prolonged exposure to the luteinizing hormone releasing hormone agonists, there's a negative feedback effect with suppression of production of testosterone. And so this is one of the mainstays of treatments. Some of the treatments, some of the average interventions that we can use include a surgical castration when the testes are taken out in a bid to deprive the patient of testosterone. You can also use the luteinizing hormone releasing hormone agonists or the antagonists, which will block the luteinizing hormone releasing hormone receptors. Estrogens may also be utilized, but these tend to have a higher risk for thromboembolic phenomenon, so they're not being used as much now. But we still use them sometimes. As we said, once you have metastatic disease, cure is not possible. And so the treatment with the palliative intent would be to maintain the quality of life and the quantity of the patient's life. Some of the major complications that can occur include that of cord compression with paralysis. So we have a patient who has a high volume of disease and is complaining of severe back pain. It's worthwhile seeing the radiation oncologist for radiation to the spine as well to help with that, as well as use of the bisphosphonates that will help to reduce osteoclastic activity in the bone. Uterine obstruction is something we see often as well, and we require either placement of a JJ stent to bypass the obstruction to the ureters or insertion of a nephrostomy tube. This is not showing up as well here, but basically it's a sort of a flow diagram showing the treatment outline for patients who have metastatic prostate cancer. Now, so initially we used to do more of, sometimes we could do a mixture of intermittent androgen blockade versus continuous, but the trend seems to be moving more towards the continuous androgen suppression. For patients who have an adequate life expectancy and have a low volume of disease, they recommend that apart from the androgen deprivation, either with an opipectomy or using the other agents that we described, the newer agents such as abiraterone, which is a cytochrome P17 inhibitor, inhibits 17-alpha hydroxylase, and so prevents formation of extratesticular testosterone. So that may be added, or using the newer agents such as thalidomide, which are non-steroidal anti-androgen, blocking the androgen receptor, also inhibit translocation of the androgen receptor into the nucleus and DNA synthesis. So monotherapy with just either an or luteinizing hormone releasing agonists or antagonists is not recommended. It's recommended that you add it to the treatment. And then they will also add for some those who are eligible for docetaxel therapy as a triple combination. What are some of the complications of therapy that we may encounter? So the major ones that can be problematic for men. And so you must have the full range of treatments available to help to encourage them. Urinary incontinence is one of the most disturbing. Patients have to be in diapers. And so, like we said, intraoperatively, every effort must be taken to avoid injury to the external uterine sphincter. You can sometimes have either a uterine stricture or a bladder contracture following the operation. You can have issues with metabolism. So you probably have the patient become diabetic, etc., hypertensive, etc. And then because of them being deprived of testosterone, or they may have gynecomastia, complain of swelling of the breast and pain. And then especially for those who sometimes have the opidectomy being done, they don't have the testes available, and this can have present a psychological burden for them as well. So in conclusion, prostate cancer remains a significant cause of morbidity and mortality in men. We are hoping that we are able to identify clinically significant cancers. And so it's important that when you're evaluating the patient, you don't proceed on the basis of a single PSA test. And make sure you counsel the patient into detail, repeat the PSA test if necessary, and then refer to the appropriate authorities. The treatment of prostate cancer is dependent on the stage of the disease. And thank you.
Thank you very much, Ken. Maybe you can have a seat over there. Our second presentation will be done by Dr. Marco. Now, he has spoken about PSA, staging, biopsy. So maybe you lay more emphasis on the radiation aspect. After that, we'll have a long panel discussion. Now, the audience.
So it's interesting that we're to give our perspective based on our specialty, because you would notice that the thing that I lay emphasis on are slightly different from what you would lay emphasis on. So, like Paul said, I won't bother you with a repeat of the bit on screen, etc. We will speak a bit about the choice of treatment, though, because, like Dr. Kuchu said, prostate cancer represents such a wide range of disease, right? You can have indolent disease that has no relevance at all for the patient, but you can also have disease that is rapidly fatal. And as I present, I would patients and to give you an idea what I talk about. All right. So this has been said already. The cancer-specific survival for prostate cancer, whether it is well differentiated, moderately differentiated, or poorly differentiated, it's about the least is about 74%. Therefore, it probably doesn't make sense to think about treating somebody whose life expectancy is less than 10 years. That is the reason why the patients who came to see Paul, the best thing to do for this patient is probably to not manage his prostate cancer at all, because he's going to die from complications of the high blood pressure. I have two cases I'll describe. The first one is the aggressive prostate cancer that is common, unfortunately, in Africans. Is the one. A 47-year-old man has no family history of prostate cancer. He presented to CAP with acute urine retention. and darolutamide in these patients, and it's been associated with improved overall, or at least a delay in the occurrence of metastatic disease. Because usually for these patients who have castrate-resistant prostate cancer without evidence of metastasis, within 2 years they will develop evidence of metastasis. And apalutamide, darolutamide, and enzalutamide defer the time at which the metastasis occur. There's also the use of radiopharmaceuticals in the management of prostate cancer. And there are various radionuclides that are used, and the various radionuclides will release different particles, and the different particles have their own benefits. So, for example, radium-223 releases alpha particles, and alpha particles are useful because they have a short range of motion, and once they release their energy, no further energy is released beyond that. So for somebody who has bone metastasis, for example, it's easy to use that. But there's also currently the use of lutetium-177, which rather releases a beta particle. It's useful because a bigger energy is released. It has a half-life of about 76.6 days or so. But it's also useful because it can be used as a theranostic. Not only are you able to treat the patient using the lutetium, but you can actually also determine whether or not they have evidence of disease elsewhere using the lutetium scans. But radiotherapy can be used in conjunction with the surgeon as well. The use of adjuvant versus salvage radiotherapy. If you've been amongst us, the radiation oncologists and the GU surgeons always have a back and forth as to whether or not patients should have adjuvant radiotherapy or they should have salvage radiotherapy. Adjuvant radiotherapy represents giving the radiotherapy immediately after the surgery, based on evidence that there's a risk that the disease is likely to fail. Usually it's in TB patients who may or may not have a positive margins, who may have positive margins. There have been a number of trials, the URTT trial, the ARO trial. They've shown that there's some benefit for the use of adjuvant radiotherapy, but at the risk of side effects. And so recently a meta-analysis called the Radicals trial was done, which shows that probably salvage radiotherapy, which represents giving the treatment only when the PSA levels have gone high enough, that it suggests that the patient's tumor is progressing to be better than giving adjuvant radiotherapy. We also use radiotherapy a lot in managing palliative cases. Dr. Preview spoke about that. If you have somebody who has back pain from metastatic prostate cancer, please don't keep the patient, because radiotherapy can actually send them back to doing what they used to do. And I always tell the story of, it's not a prostate cancer patient, it's a breast cancer patient. The husband came to us because the wife suddenly was not speaking. She had been treated for breast cancer previously and was on treatment. It seemed as though her tumor was being controlled by the treatment we were given. However, she developed brain metastasis. The patient came in with her husband not talking. I gave her steroids. She started talking. I had become a god. And then subsequently, I gave her radiotherapy, and she started going to work. Suddenly, the radiation oncologist became a demigod. So please send your patients who have metastasis for radiotherapy. It's useful for stopping bleeding, very useful for relieving obstruction, and in the case of prostate cancer, for relieving pain. Your patients can go from being on round-the-clock morphine use to just taking paracetamol because they've received radiation therapy. Thank you.
Very much now. I hope the non-oncologists follow the presentation. On the program, it's a short presentation about Zoladex. So, Sharon, and after that, there's supposed to be a coffee break, then the dinner. Yeah, why don't we just, we just continue the panel and then we have both a coffee break and then dinner at the same. Okay.
So I'd like to thank the speakers for the intense information. I think that for some of us here, we are very used to the information that was shared, but then for some too, we are not really used to the information. And this is actually the reason why we are doing this program, so that we can all understand the prostate cancer space. Okay, so I'm supposed to do a presentation on Zoladex, and I think the speakers mentioned a lot more for the treatment section. They did a lot of conversation on ADT. So from AstraZeneca, we have Zoladex. I don't know why the presenter is not showing. Okay. So basically, what I wanted to share was that they mentioned about the ADT therapies that we have, and Zoladex happens to be a gonadotropin releasing GnRHA agonist, and so it's one of the medications that have been used over the years. Anytime I come to the consulting room, I've seen most of the prescribers that I meet a lot, and we've been talking about Zoladex. We've been talking about Zoladex. Anytime I come, they are saying that is all we use here because of availability. So I just wanted to share where it is placed in. So basically, Zoladex is actually placed in high-risk localized disease. It's also placed in metastatic disease for prostate cancer. It's also placed in regional disease, especially when patients come in. When it's localized, it's not localized. ADT is actually presented heavily. So I wanted to actually show you the various stages of prostate cancer, but my slide is not. So I'll wait for the slide to show so that I can mention them. Okay. Yeah, so this was actually the first slide. What I wanted to say is life is worth living, and I believe we are all here because of the patients. I'm here because of the patient. You are here because of the patients. What we can do best for our patients, and as it's written here, ADT has been a cornerstone of prostate cancer therapy for more than 60 years. So like I earlier on mentioned, it's something that it's a medication that we use, the urologists, the oncologists have been using over the years, and has been proven to give overall survival benefits. So this is how it looks. And also our presenters also mentioned the fact that African men have high risk of developing prostate cancer, and so they can compare to other races. And I think both presenters mentioned it. So one of the things that I would also want to highlight here is the fact that we've realized that, yes, most of the patients are coming in metastatic. So what we want to encourage our peripheries, our doctors in the peripheries to do is to advocate for early detection, advocate for early screening. And as they mentioned, 40 years is actually the stage where a lot of men should start screening for PSA and all. So we encourage that once the patients come to you, when you see their age is 40 years and above, you should encourage them to be testing for prostate. It's one of the things that we want the message to go out there. Once you see their family history and all that, we encourage that you would let the patients start screening. Okay, so this is actually the NCCN guidelines, and it showed the various stages of prostate cancer. We have the intermediate, high risk, localized. It mentioned external beam radiation in there. ADT is also actively and strongly represented in there, where in this case, it's Zoladex for ADT. If you look at locally advanced disease, you also realize that external beam radiotherapy is also actively showing in there, plus ADT, which is also preferred in this stage. Metastatic castration naive, you find that yes, there's monitoring is there for the MET disease, then we have ADT also showing in there. So it's the same with castration resistance. I think one of the presenters also mentioned that initially there was using ADT, coming back to use ADT. Now it's encouraged that you continue with ADT. So Zoladex again is also represented in there. Yes, so I'm saying that yes, intermediate high risk, the benefit that Zoladex gives, it improves biochemical control and survival when added to radiotherapy. I think Dr. Na mentioned in there about the biochemical control, improving biochemical control. And then we also have the regional disease. We also realize that Zoladex maintains 10 years overall survival benefits when added to radiotherapy. I think another presenter also mentioned, speaker also mentioned in there. So immediate Zoladex plus radiotherapy shows greater overall survival versus deferred ADT. Then metastatic castrate naive, we also have a similar overall survival and time to treatment failure versus orchidectomy. So Zoladex is also indicated in metastatic castrative naive patients. Then metastatic castrate resistance, so you find that Zoladex should be continued to maintain castrate levels of testosterone while additional therapy, example abiraterone, is applied. So basically, Zoladex has proven benefits across all the stages of hormone-sensitive and resistant prostate cancer. And when you are choosing any oncology medication for your patients, you're looking at, yes, the benefits, the safety that comes with its use, and then the cost. Also, availability is also very important. And Zoladex is available in all parts of the country. When it comes to giving Zoladex to your patient, you get it anywhere in the country. It's also it has a very safe system. So it's very simple and convenient. It's a single depot injection delivered subcutaneously via the safe system syringe. So in this case, there's no problem of infections or so one-step administration. There's also no assembly and no mixing required. You need minimal injection pain in the majority of patients. Then Zoladex safe system needle is siliconized and includes an automatic safety shield that helps to prevent needle stick injuries. 100% delivery safe system. So the safety of the drug is also very important, and that's what Zoladex administration is. So basically, don't wait till it's too late, and we are encouraging that patients are screened early. Early detection saves lives. Thank you, and I'll finish.
Once again, we've been treated to a whole dissertation on prostate cancer. It's time for our case discussion. So we are going to use the case that now presented, the young man. From what we heard so far, to reduce the mortality from prostate cancer, first we have to diagnose it early, whilst it's still confined to the prostate, which we can do. And secondly, that cancer should have the potential to kill the patient. Because if that cancer will not kill the patient, and you go and treat him, when the radical procedure on him, make him impotent, make him incontinent, he will not forgive you. So our challenge is to diagnose the aggressive disease whilst it's still confined to the prostate. So let's look at this gentleman. Clearly, this gentleman is going to die from prostate cancer. And that's what our study showed. Most of the patients who presented with metastatic disease and their HP levels were less than 10, died within 2 years. So these people had very aggressive disease. So let's take this gentleman, 47 years old, presenting with advanced prostate cancer. 20 years down the line, he has a son who doesn't want to end up like his father. What can he do to prevent death from prostate cancer? So for somebody like that, screening is a no-brainer, or any contrary opinion. Screening is a no-brainer. And secondly, these are the people who are more likely to have genetic abnormalities. So for him, he should do that BRCA test, which I know is now available in country. So let's say the father did it or the son did it when he was 35, and he had a BRCA mutation. He should be very, 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 very careful. So at what age should he start doing the PSA? The guideline says 40. Any contrary opinion? Will somebody do it earlier? 35. Yes, because you've seen the radicals that we've done on the young men. We've done radical men in the 38, 36. So for somebody like that, but that is not standard. The standard recommendation is that you should start screening at 40. So let's say this man's son did a PSA test and it's 2, which is normal, or let's say 1.5. Ken, are we going to biopsy him? Yes and no? You will not. Yes, because the PSA is low. But he's a very high risk patient. Will you do the multi-parametric MRI on him? You may do. Yes. To see whether there is a para 3, 4, 5 lesion in the prostate. So you can decide to do that. You did it and he had a para 4 lesion. You go ahead and do a biopsy. Now he's not a rich man, so you can't do an MRI. You did a DRE, it's normal. You can decide to watch him. That's what we do. Normal DRE, normal PSA. We'll say do the PSA every year. So he does it the following year, and it's now 4. It's gone up. The velocity is more than 2. So you may recommend a biopsy. Then you do a trans biopsy, transrectal ultrasound guided biopsy. And it came as normal, no evidence of cancer. Does it mean he hasn't got cancer? The transrectal biopsies that we do, we take only about 1% of the volume of the prostate. So the needle can easily miss where the cancer is. So there are times that if the risk is high and the biopsy is normal, we do a repeat biopsy. Now, if you do a repeat biopsy transrectal and it's not normal, we know that that is not the area. Again, because you can have the cancer in front of the urethra. Now, if the disease is arising from the anterior aspect, you can do 1,000 transrectal biopsies. It will come as normal. So these are the cases that we may recommend a transperineal biopsy to make sure that there's nothing hiding in front of the prostate. So Kent, this patient did that, and the result came CA prostate, Gleason 3+4, and he's 41. PSA less than 10, Gleason 3+3 or 3+4, they are really normal. Are you going to stage before? Now you are saying that these are low risk. So we shouldn't do the bone scan, we shouldn't do everything. But we tend to do that in our environment because we don't trust the PSCs. There's nothing more disturbing or more worrying than doing a radical prostatectomy in a patient with advanced prostate cancer. So because we don't trust the PSC, we trust the histology. But in case you don't know where the histology is coming from, maybe it's 3 plus 5, and the pathology is 3 plus 3. Because we are not 100% certain about these parameters, we tend to investigate everybody. We tend to stage all. But let's add something to it. Let's say he came like his father with bone pain, back pain. We're not going to request for a PET scan, or no. And that's something that we should be very careful about in our environment. We shouldn't waste the patient's money. Before requesting for any staging test, do a thorough physical examination. A patient with back pain, anemia, you can just do a plain X-ray. And that will be the end of the evaluation for the staging. It doesn't have to go to Nigeria to go and do a gallium PET scan. In the environment, we should always look at the cost involved. So if your physical examination suggests that the cancer is localized, no pain and all that, then be careful. Now, everything is normal, no bone pain. You see you at the clinic. Anemia, no anemia, HB 14. You are not going to request for a plain X-ray, or it's a waste of money. Because before, as you said, before the bone scan, the plain X-ray becomes positive, about 50% of the cancerous part of the bone should have been taken up by the tumor. So if we have a few cells in the bone, the plain X-ray will be normal. So in such a situation, we are more likely to request for the expensive tests. In our environment, we have the bone scan. We even have a PSMA SPECT scan, and we also have the MRI. So your patient, for instance, the MRI showed 2.3 centimeters node in the pelvis. The same you can get a similar thing in a patient, 2.3 centimeters. Does it mean that it is metastatic? Maybe it's just inflammatory. So if a patient with localized disease, you upstage it as metastatic, then you will deny him the chance of a cure. On the other hand, if it is metastatic, and you go and offer him all these treatments, radical prostatectomy, brachytherapy, you waste their money, you make him incontinent, impotent, and you don't cure him, it's a catastrophe. So the staging is critical. Moving on. So this young man, now he's 50 years old. PSA 57, like his father. That's what he presented. Adeno biopsy, Gleason 5+4. No evidence of mets. So now this is a high risk localized prostate cancer. Will you go ahead and give the radiation, or you give him radiation plus ADT? What is your opinion on it? This one, I will let you speak.
Very high. And once there's no evidence of metastatic disease, then you can attempt to treat this patient with curative intent. However, currently, there's evidence for the addition of. All right.
And we are waiting for the questions online. Please, audience, if you have any questions or contribution, just lift up your hand and then we'll call you to make your contribution.
So I was saying that this patient has very high risk prostate cancer. So in the absence of evidence for distant metastasis, you can't actually intend to treat him with curative intent. However, these are the patients who are likely to fail within 5 years. And currently, there's evidence for and ordinarily for these patients, you would have treated them with external immunotherapy, NADT, long-term ADT. But there's current evidence for the addition of abiraterone to the treatment of these patients together with radiotherapy. And that delays biochemical recurrence as well as improves overall survival. So you'd have to add some more systemic therapy to the treatment of such a patient.
There's a question.
So I think
Yes, please.
Hello, thank you very much for the presentation. It's been very educative. I am more at the primary healthcare level, and I have a couple of questions. There was one thing the first speaker mentioned about not doing screening for people over a certain age and with respect to their life expectancy, so we shouldn't even screen them in the first place. I wasn't very clear on that. And secondly, you mentioned going from PSA straight to MRI, but what about doing ultrasound? Maybe the transabdominal or even the transrectal ultrasound to get a better picture before we know whether we should forward the patient to a specialist. Thank you.
Can you answer the question as screening first before the image?
Okay. Thank you for the question. So knowing the natural history of prostate cancer, we know that it may take about 10, 15 years to kill you. Maybe it's one of you may die from other causes rather than the prostate cancer. If the patient's life expectancy is less than 10 years, they are 75 years old, then they are unlikely to die from the prostate cancer as the cause. So you may find that you would have, we know that at that age, he may likely have indolent cancer. Meanwhile, if you do a screening with a PSA or DRE and you pick up an elevated PSA, you're going to subject him to a prostate biopsy with risk of sepsis and possible death. Not to mention, if you go ahead with other further treatments, radiotherapy, surgery, whatever, then you have additional complications that can occur. And so if the life expectancy is less than 10 years, they're likely to die from other causes other than the prostate cancer. And so the recommendation is not to screen them and put them at risk of the various complications that may occur.
And the life expectancy is not the age. It's it's not a chronological age, it's the biological age. The person is 70, but he's got 2 girlfriends, he's wearing chains, he's 50. He's got many years ahead of him. The guy is 60 years old, he's on 10 drugs, he can't walk, he's 80. So we look at what's called the biological age, not the chronological age. Now, you can't use ultrasound to screen for prostate cancer. You can use it to determine the size of the prostate, the bladder, the hydronephrosis. But there is no feature of ultrasound that will tell you that there is cancer there. So the ultrasound that we use, the transfer ultrasound, is to guide the needle. In the past, it was thought that if you see, and Dr. Kaminta is here, the radiologist, as he left, he's better at it. It was thought that if you see a hypoechoic node in the prostate, it's cancer. But from several biopsies, we've seen that that area may not be the cancer, but the cancer may be adjacent to it. So we don't use ultrasound on its own to screen for prostate cancer. That's all.
What happened
the usual catheter, it was removed. He currently doesn't have a catheter. Yeah. Oh, that's it.
Any questions online?
So, okay, good evening. Thank you for the informative presentations. Does a 43-years old patient with PSA of 0.2 ng mil, I need to do prostate scan as a screening tool? Is the question clear?
It's clear. Ken, will you add? I would say no.
Yeah. So I'm assuming that if he's in Ghana, he may likely to be African. So that puts you at a higher risk for prostate cancer compared to the white per se. So once you're above 40, that according to the HCPs guidelines, the indication is that you should screen for prostate cancer every 2 to 3 years.
And he's done his PSA. Yes, and it's 0 point something.
0.2. No, it wouldn't get that warrant.
I will tell if he comes to see me, do a rectal examination. And if it's normal, I will tell him to go and enjoy his life. But if he has a strong forest of prostate cancer, we'll tell him to come next year. Every year he does the PSA and take from there.
Okay, so in the past, it's been said DRE causes increase in PSA. And so one must be cautious in interpreting PSA results after recent DRE. Is it no more the case? Asking because I didn't find it in your list of causes of raised PSA. That's the first question. Then, as far as I remember, I stand to be corrected. Most prostate cancers are adenocarcinomas, over 90%, and these tend to give osteolytic lesions for bone metastasis. Thus, most bone mets are osteolytic lesions. Do we have any change in this trend?
So I think I'll answer the last question first. So for prostate cancer, what you tend to have more is osteoblastic lesions. With the spread of the cancer to the bone, there's an alteration in the balance between osteoblastic and osteoclastic activity. And you tend to have more bone deposition. So you tend to have these dense white areas, sclerotic areas on the bone. Yes, so as we mentioned, the PSA tends to, any manipulation of the prostate can lead to an elevated PSA. So a distal rectal examination, if you do a prostatic, as you're massaging the prostate to evaluate for the presence of nodules, you may have some increased PSA being released into the bloodstream, and the PSA may rise.
And to add to that, we see a lot of patients coming with elevated PSA. We don't act immediately. First, we repeat it. We look at it. There are a lot of bogus labs around, we all know. So we repeat it. If the patient has any evidence of urinary tract infection or whatever it is, you do the urine culture, treat any infection before taking an action on the PSA. The point I made about doing a DRE in the presence of a normal PSA is that there are some aggressive tumors. They are so aggressive that they are not producing PSA. So the PSA will be normal, but the patient will have an aggressive disease. That is why although people frown on DRE, any patient who comes to our clinic about 40 with even a normal PSA, we will just ask you politely whether we can put our finger there. If you say no, we'll leave you alone. But if you allow us, with your permission, we'll fill the back of the prostate. And from one of our studies that we published, if the DRE is abnormal, the probability that there's cancer is as high as 30%. And these cancers tend to be very aggressive. So a DRE is still useful in our environment. Elsewhere, they are doing MRI for it to come MRI. But compare the cost of gloves and disposable gloves and KYGL, Vaseline to MRI of that. So if you don't want, some people, I don't want my finger, okay, then you go and do the MRI. Come. But that is 5,000. Please do the DRE for me.
We always have to remember that there's no PSA level at which the risk of having prostate cancer is 0. And so once the patient comes, if you have the option to examine them further, if it's a rectal examination, do it. then you can be sure that it's unlikely to be prostate cancer, because you can't actually have somebody with a PSA of 2 and they may have prostate cancer.
Okay. I just have a question. There are different types of metastatic prostate cancer. So I think it's something to touch about because they are very long. We shouldn't give up on them.
Ben, can you?
What I mean is that there are
expatiate?
different levels of metastatic disease, is not just one group. So those with low volume can actually live very long with extra radiation and therapies versus those with multiple metastasis. So we shouldn't give up on our metastatic disease. They are different types. Some of them have lymph node only, some of them have bone only, some of them have soft tissue involvements. So there are different types of metastatic disease, and all of them are managed differently. So you are more aggressive with those with limited low volume metastatic disease, of which the criteria varies. It depends on which year and whatnot, basically. But I think it's something that we need to categorize them, because they can outlive you, the physician. So we just remember that.
And then the study that we published, there were patients who came with metastatic disease, but that was something else. They're from something else. And that's why it's important for them to come early. Because when they come early, they are fit for all these newer drugs that are available. If you come anemic, so weak, abiraterone, enzalutamide, all those drugs, you'll not be fit for it.
So there's another question. Please, what should be the frequency of testing or screening for prostate cancer? The frequency.
So thank you for the question. So the screen, as you said, first thing to do is the age, and then also checking your race. So generally, with African race, you're screening 40 years and above. So we're doing this every 2 years or so, repeating the PSA, as well as having a rectal examination done to assess the prostate.
And also your initial PSA. If the initial PSA is 0.1, the frequency will be different from if your initial PSA is 2. So if it's that low, 0.1, you can do it every 2 or every 3 years. But if it's more than 2, then maybe every year.
Thank you very much. Dr. Anna, your presentation, the first case, the 47-year-old man. If the PET scan was not affordable, and with the 2.3 year LV, would you have treated differently?
Okay, so to be honest with you, the presence of the 2.3 cm lymph node suggested to me that he had disease outside of the prostate gland, mainly because he had very aggressive disease, right? To start with, he's 47, and the glycemic score was 5+4, and all the cores were involved. So if he couldn't, what I needed to know was whether or not he had low volume disease or high volume disease, so that I can determine whether I wanted to add radiotherapy to his treatment or to add more systemic treatments to the ADT that I was going to give him. So that was the reason for the PSMA PET scan. If he couldn't afford it, it would be a bit, probably I would have asked him to do a whole body MRI with the hopes of finding bone metastasis elsewhere. Because the truth is that in this patient, if he couldn't do any further tests, and I assume that he just had lymph node disease, if you treated him, he's going to fail in a few years, right? Because he actually has distant metastatic disease, but your imaging was unable to show that. So it would have been difficult to make a decision on the choice of treatment, to be honest.
And I love your question, because we'll be getting from that is will change outcome or is actionable. And it's something that all of us as leaders, every single test that you are requesting for, because of the cost involved, that the result of that should make a difference in the treatment plan. I know Dr. Vanderpool is shaking her head.
That, like again, if I say this limited disease, they can be radiated and they can live for long. Or that's what you are going to observe. If you just think that it's only the prostate bed, then maybe she doesn't need radiotherapy after all, because it's already in the mediastinum, or you treat both. So for us, we target what we see. So I think that's the reason. So from our point of view, if the patient can afford it, especially for recurrence, or patient has a PSA of 300, you want to know where the disease is to know what to do. So basically, that's why. So we are more like a plan case, basically.
Another. Thank you very much. My last question. There's this, should I say, thought or this idea about prostate cancer that it's a progressive disease and will eventually end up with castrate-resistant disease, and it's like it's inevitable. So sometimes when even the possibility of that is mentioned, the patients are quite wary and they think it's a death sentence. So I wanted to ask, from our practice in the country here, how often do we see remissions and those kind of things? How long do we see them being able to live, should I say, cancer-free or like functional lives with the prostate, the diagnosis of prostate cancer, especially if there's a family history?
Okay. You see, from the study that we published, patients coming with localized prostate cancer, their outcomes are very good. Very, very good. Even patients who have metastatic prostate cancer, those who came in with a good HP, like more than 13, they live for 7 years, many years. So it's not necessarily a death sentence. But if you come with very advanced disease, you stay at home, sometimes they go to the herbalist, they give us concoctions, and they are only referred when they are anemic, paralysis, then it might be the cause of your death. But if it is diagnosed early and the appropriate treatment is given, it can be a chronic disease. And now with these newer drugs, the only problem is that your pocket may suffer, but they are living longer and longer and longer.
I'm just a little worried that there's a perception out there that prostate cancer is a death sentence. In fact, prostate cancer is one of the cancers that is not a death sentence, because your patients can live for long. We've had patients who come with metastatic disease and you just do an oncectomy and they live for 5 years. So it really is not a death sentence. Like Dr. Vanderpool said, the patients might outlive you, even with metastatic disease.
So, there's another question online. Okay, it says, bosses, how can we standardize PSA testing in Ghana? And is PSA done at Kolebu Teaching Hospital trusted?
I'm sure I saw somebody signed from Ghana Standards Board or a Food and Drugs Board. Oh, there's somebody from there, right? Uh-huh.
So the question was to bosses. I don't know if the bosses here, but the bosses.
We are tired. So what we do is that we will blacklist you. Because I think there are authorities in this country who are responsible for that, or Reverend, your group, you should act. Yes. All that we can do is to label you that place, that lab is bogus. And we won't send any patient to you. We would like your reagent to expire you. Next time you will be doing PSA again. But Reverend, any comments?
So I think currently, as far as I know, there isn't a national standard for that yet. on our part, as new entrants and where our goal is, our approach has been to ascribe to the international standards. So on the US side, it's the ISO equivalents, which is typically clear, or ISO 15189, or the 20387 if you're biobanking as well. And specifically in our instance, that's what we've done, where we've spent a whole year after launch, just going through local regulatory steps and international ones. It's our way of saying, this is the standard that we're ascribing to, so that whatever test that is sent out is to that standard. And that's the approach that many new upcoming ones are doing, especially if we're going into the molecular and genomic testing, which is where we're focusing on. And it's also with the view of looking long term, because we're not just doing these things for today. It's a long term view to say, as a country, what is our baseline? And then we can move on from there. Because with the genomic testing and molecular testing that are coming up, the question or the challenge that we face very quickly is the polymorphism of these targets that we look at. So you can be in Ghana or in Africa and have a test sample sent out for, let's say, a BRCA test. It's a polymorphic target. How do we know that the assay that's being used is sensitive to our population? That is the question, and that is why we are going at it this way to say, let's build local data to inform these things.
All right, so I think there's a last question. And this question is to us, AstraZeneca. So I also say bosses. Is the Zoladex always available in the pharmacy, and how much? So, boss.
I think I'll give one. I'm the senior Kusuda. Anyway, so Zoladex is very much available in the country. And it says how much? So between 3,200 and 3,400, you should be able to acquire a pack. However, we have some products that have illegally entered the country from other jurisdictions. And usually our concern is even about how it was transported, considering that Zoladex is an injectable medication, and we keep it through our distributors under very strict temperature controls. When we have these illegal entries, which usually come very deep to the patient, it becomes a challenge. We are working with the FDA to see how well we can clamp down on some of these guys that do this kind of business. But then once you go to our accredited distributors, NS Chemist, East Cantonment, Osoms Worldwide, I mean, any of these guys can get you their authentic pack, or you can reach out to any AstraZeneca rep that you know. They can definitely help you reach out. And Kolebu also usually regularly stocks, and they usually have it at the 24-hour pharmacy. 37 usually also have it at their 34, the 37 chemists. So it's very much available, and it's quite, we've heard of instances where people are buying it for outrageous prices, 4,000, 5,000. And considering the situation of these patients, I mean, they shouldn't be spending that much. Once you pick up on something like that, please let us know. We are going to trace these people. If it's an authentic pack, we'll get them to reduce the price. If it's an illegal pack, we'll get the FDA to work on it. And I mean, just a couple of days, I was in a meeting with the FDA CEO trying to think about how we can work on these things. We'll talk to our colleague pharmacists so that they comply, but we'll also depend on you to be able to direct them to the right sources. Thanks.
Thank you.
If it could be even cheaper than 3,200, probably the parallel imports would also be. 3,200 is not that cheap.
So, I mean, just recently we were in a conversation with Prof. discussing, what we could do in terms of intervening when it comes to price for the patient. So there's a project that's still in the formative phases that we want to put out. And once it's well put together, we'll definitely call another meeting like this to inform you about this project. And that one is directly targeted at reducing the products directly to the patients. Because in the past, when we reduce the product and give it to the pharmacies to pass on the discount to the patients, unfortunately, it doesn't get to the patient. So we want to work with the society, the oncologists, and the surgeons, the urologists, to be able to assess the patient directly with this discount, because that is where it will benefit them. So we will come to that, Dr. Na. You can have my word on that.
All right, thank you. So the last one is, please, can you share your views on sexual activity and risk of prostate? So that's the last question.
Yeah, thank you for the question. I think it's a question that comes up very often. And there's a myth around that increasing sexual activity actually seems to increase your risk for prostate cancer. That isn't quite true. There were some studies in the US that seem to suggest that the more ejaculations you have in a month, the less your risk for prostate cancer. So please go ahead.
You didn't mention a number of ejaculation your mouth to 27. Anyway, in the absence of any further questions, let me thank my co-panelists. I hope you enjoyed their presentations and they did I hear our food is waiting, but there is a short video from Reverend. So please listen to that before going to our dinner. Thank you very much.
Revna Biosciences is a biomedical research company that offers clinical and diagnostic services with the goal of bringing value-based healthcare to Africans. Our unique approach integrates biomedical research insights with clinical and diagnostic services as essential components for the advancement of medicine and
precision medicine and for disease treatment considers individual variability in genes, environment, and lifestyle. Revna Biosciences believes that this approach, when used by doctors and researchers, helps predict more accurately which treatments and prevention strategies for a particular disease will work in a particular group of people. This approach contrasts with one-size-fits-all approach in which disease treatments and prevention strategies are designed for the average person, but precision medicine considers the investigation of the individual genes before adopting therapies for better health outcome.
With an operational base in Accra, Ghana, Revna Bio is conveniently positioned to impact lives right from the heart of West Africa, with access to a growing network of healthcare facilities and diverse patient population. Additionally, with its multidisciplinary laboratory facility, Revna Bio is equipped to conduct a wide range of targeted biomedical research while providing much needed clinical research and molecular diagnostic services. The Revna Bio facility has, among others, a dedicated sample receipt and processing lab, a PCR lab, general microbiology, post-amplification, node template, and a multi-omics unit, all of which have been medically engineered and operated at the biosafety level 2 category. Our virology and bacteriology laboratories have been engineered to operate at the biosafety level 3 category. We also have a bioarchive of short and long-term storage of biological samples for current and future research in areas of biomarker discovery, disease characterization, diagnostics, and therapeutics.
This is Revna Biosciences bioarchive, where we store tissues for diagnostics and research purposes. In our bioarchive, we have a refrigerator that has a temperature range of 2 to 8 degrees Celsius for storage of consumables that have that temperature, and samples as well. And we also have the negative 25 degrees and negative 80 degrees freezers for storing samples that have that temperature ranges to keep them viable for the purposes. And then aside the fridges and then the refrigerator, we have the fume hood and then the biosafety cabinet that we use for tissue grossing. And then after grossing tissues, we process the samples, embed, microtome, then we put them on the slide and then stain them for microscopy. Aside the storage devices like the refrigerators and the freezers, we have a liquid nitrogen container that requires the liquid nitrogen, which is used to store samples that require that kind of storage environment for the sample's viability to maintain for the intended purposes.
With these fully equipped laboratories and a highly dedicated and close-knit team, Revna Bio is primed to contribute to impacting lives in the infectious disease, oncology, and a host of other non-communicable disease areas. In a bid to fill the global genomic dataset shortage involving insights from Africans, we have partnered with Diatech Pharmacogenetics and Keogen GmbH to make precision medicine accessible in the region. With these key partnerships and a commitment to global quality standards, Revna Bio is playing its part in introducing practical, novel solutions to the region and shortening the distance between the lab and our communities. We have also partnered with Microsoft and Amazon Web Services to utilize their cloud computing services, software systems, as well as their dynamic analytics and applications to further augment our technological infrastructure. With the core of our work fully centered on our patients, measures have been put in place to ensure that their rights in relation to personal data are not compromised. In very practical ways, we care about the comfort and privacy of our patients or clients. Therefore, we have a dedicated concierge officer to ensure that we remain true to this goal. Further, our facility provides a modern, secure, and welcoming environment with well-trained and committed staff for walk-in clients. The Revna Bio team's expertise covers the full spectrum of clinical, diagnostic, and research services with experience from across the globe, yet it's grounded by a deep understanding of our local institutional voids.
Given a focus on harnessing the power of data insights, Revna Biosciences has invested in data scientists and bioinformaticians who apply the tools of computation and analysis for the capturing and interpretation of complex and unstructured data into meaningful insights to promote precision medicine.
Revna Biosciences believes in the power of collaboration and is therefore actively pursuing and developing partnerships with Noguchi Memorial Institute for Medical Research, Kolebu Teaching Hospital, University of Ghana Medical School, Kumasi Center for Collaborative Research, University of Cape Coast, Pathologists Without Borders, and the 37 Military Hospital, among others. Through these collaborative efforts, we contribute to the advancement of biomedical research and offer a platform for the development of the next generation of scientists and clinicians. We provide access to graduate and medical students to utilize our multidisciplinary facility for the conduct of their research project, cooperative assignments, practicum, internships, and other training opportunities to ensure that the next generation of scientists and clinicians are equipped with the tools they need to address future challenges locally.
In line with our mission to increase the access to and the discovery of advanced molecular diagnostics in Africa as an essential step towards the enrichment.
For the audience, this is our